Hey everyone, thanks for joining us here at Dietitians and Nutrition Support today as we chat a little bit about electrolyte disorders, particularly those revolving around sodium. So if you're familiar at all with sodium electrolyte disorders, you'll know that it's one of the most common, if not the most common electrolyte disorder that you'll see, including both hypernatremia or excess sodium and hyponatremia or decreased sodium levels. Unfortunately, sodium imbalances are very highly associated with morbidity and mortality in your patients, upwards of 2 times the risk compared to an individual without a sodium imbalance problem. So it's definitely an important piece for us to understand and hopefully be able to help manage in our patients. If we're thinking about sodium in general, you'll probably know from our last video that sodium is an extracellular cation. So it requires some sort of active or facilitated transport to be able to move across the cell membrane, but for the most part relies in the extracellular fluid. It's also really important for being able to conduct action potentials, so helping to make nerves and muscles function. So obviously it's going to be super important throughout the body, not just for skeletal muscle, but all the other muscles that function without us even thinking about it. In general, sodium really helps to maintain extracellular fluid volume. If you've ever heard before that water follows salt, if there's sodium highly concentrated in a particular tissue or location in the body, it's very typical for water to follow. So this can be a problem when you have too much salt or too little salt somewhere. You'll see fluid imbalances too. So in general, also, if you have a fluid imbalance, that can then, of course, lead to sodium problems as well, just because they're very closely correlated. So let's go ahead and jump over to the other screen and we'll talk a little bit more about what a normal sodium level looks like, as well as how to manage hyper and hyponatremia.
All right, so when we're talking about sodium status, for the most part, we're going to be using sodium lab values to help determine our patient's sodium status. Although the values that you're going to use at your institution may be different than what I'm going to use today, for the most part, the goal ranges for sodium status are going to fall somewhere between 135 and 145 milliequivalents per liter. So if we jump over to the side here, we'll see hypernatremia, which is going to be an increased sodium status. So that's obviously going to mean we're going to be somewhere above the 145 milliequivalents per liter. And on the opposing side, we'll see hyponatremia, and that's going to be when we have the decreased status of sodium, which is going to be below 135 milliequivalents per liter. So for both hyper and hyponatremia, you'll see that we've classified them into groupings based off of volume status. So individuals with these specific classifications will see not only the changes in their sodium status, but also a correlating volume status that helps us to prioritize what ways that we can help manage both the sodium and the volume status. So looking at hypernatremia, that's going to be that excess sodium status. We'll note that hypernatremia in itself is a hypertonic state, meaning that you have an excess amount of solutes in the bloodstream, so that's going to cause for water or fluid in general to go from the intracellular fluid towards the extracellular fluid. So it's very typical to see water movement into the bloodstream at this point. So our first of the hyponatremias is going to be hypovolemic hypernatremia. So we have some decrease in volume with a corresponding increase in sodium status. This typically happens when you're seeing a decrease in body fluids. And this can be through urine, diarrhea, sweat, diuresing, excessive diuresing, somewhere in which the water loss is going to be greater than the sodium loss, so it leads you to having this increased sodium status. Treatment for the hypovolemic hypernatremia is going to be a use of a hypotonic saline solution. So you could see this being a quarter or a half of normal saline to help provide additional fluid and replenish that fluid status. In some cases, we might see isovolemic hypernatremia. So there is a neutral change in volume, no change big there, with an increase in the sodium status. So this can happen from some decreases in free water in the body without correlating decreases in the sodium status. Sometimes this happens from insensible losses, and that can be through skin or the lungs. And the best treatment plan for this is going to be water replacement. And you'll see that that can happen through IV fluids, or it can also be from oral fluids. Hypervolemic hypernatremia is going to be an instance in which we have an increase in volume and an increase in sodium status. This can take place oftentimes with some sort of excess in the IV fluid administration, particularly if it's a normal saline, and that can lead to just this sodium gain as well as a volume gain that is going beyond what the patient actually required. Some proposed treatment ideas for this include diuresis, as well as seeing if there needs to be any fluid replacement. And finally, of course, IV fluid adjustment, especially if that is kind of the instigator for leading to this hypervolemic hypernatremia state. All right, so let's move over to the hyponatremia side of things. So first off here, we're going to see a hypovolemic hyponatremia. So we're seeing that decreased volume as well as a decreased sodium status. We can see the state in times of renal loss, third spacing, as well as GI loss. The management for the hypovolemic hyponatremia is going to be an increase in volume in general, including both water and sodium. The isovolemic hyponatremia is commonly taking place in which there is some increase in total body water, not necessarily blood volume itself, but the total body water that's leading to some dilution in the sodium status. And most of the time, this is going to be related to some sort of a medication. And we could see that with like medication-induced hypothyroidism or various other states. Treatment for this is going to include a decrease in water to try and decrease the total body water and help to kind of mitigate this dilution of the sodium status. So next we'll have the hypervolemic hyponatremia. So obviously that means an increase in volume, and this can often be related to that increase in total body water or just water in general, as well as sometimes you'll even see an increase in sodium status, but more so it's kind of this increase in the fluid that's available as opposed to the sodium. So we're still seeing so much fluid there that it's kind of diluting our sodium status. So not always is your patient actually seeing a total decrease in sodium, but they may just have that dilution happening. This can happen in times of renal failure, in terms of liver failure, heart failure, and other edema as well. And the treatment plan for this is going to be both sodium and water restrictions. So again, we may see an increase in the actual sodium that's available, but it's kind of being diluted out by the fluid status. So while we're seeing, we're going to limit the water that's provided, we may also need to limit the sodium that's provided as well, just barring the fact that our actual sodium status was probably diluted by the total body water that was available. Finally, in terms of hyponatremia, we're going to see what's called translational hyponatremia. And so this is actually going to be an instance of an elevation of blood glucose. So this elevation of blood glucose is also a hypertonic state, which means that we're going to see that movement of water from the intracellular fluid towards the extracellular fluid in hopes of dilution of this blood glucose status. So with the increased water movement, we're going to see that causing for a depletion in our sodium status, or what looks like a depletion in our sodium status, just based off of, again, that dilution happening. So management for the translational hyponatremia, we have to keep in mind that the etiology is related to the blood glucose status. So if there wasn't the excess blood glucose, we wouldn't see the rush of water into the extracellular fluid, and we wouldn't see this big dip in our sodium status. So there's no true guidelines for how you should try to replete someone when they have translational hyponatremia, but mostly you're looking at blood glucose management, and that should help you to normalize the sodium status. And then just watch carefully to kind of see if there needs to be any additional interventions beyond that. It's important to note that hyponatremia in particular kind of has a lot of different etiologies that it can come from. So some of the ways that you can help to sift those out can include doing a urine sodium test. And being able to see the urine sodium test can kind of help you to identify whether or not it's a renal related loss or it's an extra renal related loss. So this is kind of a nice starting point. If you don't know exactly what's happening with your patient, you can help to parse out why they're having issues with hyponatremia, and then you can make your best management plan. So some other important pieces to note about hyponatremia in particular is you may see patients that show up having some sort of neuro dysfunction. So they may have neurological symptoms that are just atypical for them, but this is very indicative in cases of hyponatremia of acute hyponatremia, and it's less so present in chronic hyponatremia, although it can occur. Now with both hyper and hyponatremia, you want to take your whatever management plan really slow. So the reason for this is because obviously we've talked about how sodium and fluid are very closely correlated. So when you change the sodium status, you also are going to make big changes to the fluid status because the fluid's going to go where the salt is, right? So if you have too much quick movement of fluid in and out of cells, that can cause some sort of cellular dysfunction. And in particular, we're quite concerned about the osmotic demyelination within the brain. So you can cause further neural problems if you have any of your repletion or fluid provisions taking place too quickly. So at least in terms of repletion, there's some kind of general guidelines that you do not want to exceed 10 to 12 milliequivalents per liter in 24 hours. And you also don't want to exceed 18 milliequivalents per liter in the first 48 hours. So both of these guidelines for repletion can kind of help you to take it slowly and make sure that you're not providing too much sodium too quickly. But again, on the other side of things, if you're providing any other fluid, whether it's the hypotonic saline or other types of IV fluids, you want to take it slowly for hypernatremia as well, just to kind of avoid any instances in which fluid's moving too quickly and you could put your patient in danger. So let's move back to our other screen and we'll wrap things up.
So just some general reminders regarding sodium. If you are looking at sodium, you may see it compounded in a few different types of salts within a parenteral nutrition or within an IV fluid bag. So if you are considering sodium, it could be compounded with chloride, acetate, phosphate, lactate, and various other types of compounds to try and help make it stable to be infused into your patient. So if you have any questions about that, I recommend that you talk to the compounder and the pharmacist that works at your institution to try and understand what are the best use cases for each of those, what's most common, what's most recommended for specific states, and various questions regarding maybe your specific patient as well. If you are thinking about sodium requirements for your individual, keep in mind that all of our patient care is going to be individualized. So if you really need to make a recommendation, it's not just going to be based off of these general guidelines in many cases. So you need to make sure you understand not only your patient's fluid level, but the sodium requirements that they're probably going to have, their organ function, and all those other things, kind of like we talked about in our first video regarding electrolyte imbalances in general. Also, a reminder, you don't have to infuse sodium in the parenteral nutrition bag. You can put it in a separate IV infusion, and that's obviously very common. I mean, we see people infusing with normal saline all the time. So just keep in mind the way that you're infusing sodium doesn't always have to be in parenteral nutrition in all cases. And remember that you're a part of a care team. So when you are trying to make recommendations for any of these things, whether or not you feel super confident in what's happening, it's just always important to talk to the care team and see what their thoughts are on this and try to help make sure that everyone's on the same page and that we're making the best choices for your patient's care. So thank you so much for joining us for this video about sodium. I hope it's been helpful for you to understand some of the various states that you might see your patients in and potentially some ways that you could help to make recommendations to correct some of those. If you're interested at all in more videos on electrolytes, we'll have those coming to you in the near weeks, and we look forward to seeing you soon.